Good morning or afternoon or evening. I don't know where everyone is. My name's Angela Bailey. Can you hear me?
Yeah, we can hear you fine.
Yes, we can hear
Great.
you.
Great. I can't see anyone, so I hope everyone's doing well. Our session today hopefully will be very exciting for those who've joined us. I see a few in addition to our presenters are here. So everyone should have access to their microphone and to their video, and you're welcome to use the chat room as well for questions or discussions that you might have as we're moving along through our presentations. We're going to have 3 different presentations to start us off. But our session is about supporting citizen researchers and how to promote action research for health system change. And we have presenters that have worked extensively in India. That's Neeta Hardikar from ANANDI, and Vincent Majune from Uganda, and Walter Flores from Guatemala, though Walter currently is not based in Guatemala. And my name is Angela. I work at the Accountability Research Center, which is an action research incubator based at American University, the School of International Service. So I've worked with Vincent in the past and also with Walter to a lesser extent. And I've just gotten to know Neeta and ANANDI through the process of preparing for this session. So we are excited to see a few others here joining us this morning. So I'm going to go ahead and pull up our presentation. So hopefully everyone can see the presentation. I can't hear anybody. Can somebody indicate if they can see on the screen the presentation supporting citizen researchers?
No, I cannot hear.
That's darn. Thanks, Walter. Can you see it now?
No.
Oh
Not.
dear.
No.
Oh dear. I'm sorry. This is my technical failing here.
Hi, Angela. Is there share screen at the bottom of Zoom?
Yes, that's what I've done.
Okay.
I've done to share screen, then I go to my Dropbox.
So try on basic and then choose the Dropbox.
Okay, let me start over. I'm sorry to everybody on the line. I see a few additional folks have joined us, and we want to hear who you are. I'm just working on my poor technical.
Angela, you want me to try sharing it from my computer?
Perfect, Neeta. We see your screen
Can't
now.
see it.
If you just want to make it full screen. And Angela, you are muted. This is perfect. Thank you.
I can do the slide presentation, Angela. You can start.
Sorry, morning everyone. It's morning where I am. It's 5 a.m. here in California. Welcome to everyone in the session. I would like to start us off by introducing our presenters, Neeta Hardikar from ANANDI, Vincent Majuni, formerly of GOAL in Uganda, and Walter Flores from CEGSS in Guatemala. And each one of them is going to share insights and information about the work and the approach that they've taken to supporting citizen researchers working on health and advocacy and action around health in their own contexts. So Neeta will start us off. Neeta, can you go to the next slide? This is just a perfect, thank you. So we'll hopefully folks will be most interested participants will hopefully be here in the next minute or two. Again, please feel free to ask any questions in the discussion or the Q&A in the on-air portal, and I will do my best to monitor them. My co-hosts are Neeta, Vincent, and Walter, so if anybody sees anything, you can ping me and tell me what I'm missing and tell me to pay attention. So we'll spend about 30 minutes for each presenter, Neeta, Vincent, and Walter, to go over their work in each of their contexts. And then we'll have some time for question and answer, but you don't need to wait until that 15 minutes. If you have questions as we're going along, please feel free. And then after that question and answer, each of our presenters, first Walter, then Neeta, then Vincent, will go into some more details about some of the tools and processes that they have used to support citizen researchers and citizen-led research in health. And then we'll have some more discussion and question and answer, and then wrap up, talk about any similarities or questions. And then at the very end, we have a slide with some resources for everyone that's interested in learning some more. So if anyone hopefully we're all ready, we can move on to Neeta's presentation. Great, so this is just a little preview of some of the work that we're going to be learning about today and learning from. We'll start with India, so you can move on to the next one, Neeta.
Yeah.
Great. So Neeta has been working with ANANDI which means joyfulness in Gujarati, which is in Western India, working on women's rights in rural and in tribal areas, focusing on building and strengthening grassroots leadership of women and organizing cooperatives, which Neeta is going to tell us a little bit more about. And with that, I'm going to hand it over to you, Neeta. And if you'd like me to control the slides, I don't think I can, so you're going to
No, I'll go ahead.
do all the duty. Perfect.
Thank you, Angela. Thank you, HSR conference organizers, and thank you, participants, for joining this workshop. We look forward to sharing our work and learning from each other here. ANANDI, as you see in the slide here, is one of the feminist organizations in India, in Western India. The map shows some of the regions where ANANDI has its presence. And our work is largely into looking at building leadership of women in the most deprived areas of Gujarat, the state where ANANDI works for last 25 years. These are areas where tribal populations are residing. There are forest dwellers, there are salt pan workers, and other agriculture and migrant worker populations here. Women's organization formed in this area are actually looking at rights and entitlements of the areas where they work, and also other communities in the villages, which may not be active members of the organization they form, but are most deprived and vulnerable because of either access to services or the area being so deprived and underprivileged that the services don't reach there. So difficult to reach areas and difficult conditions in which communities live are where is the area where ANANDI works. Some of you probably, if you know about the Indian local self-governance system, each village is called is part of a village panchayat. Village panchayat is actually the elected body, which is formed every 4 years by the electoral process in the village, and this gives a lot of power to the community to decide not only the development plans, but also take charge of the resources that belong to the area where they live. So there could be the water, the forest, the other natural flora, fauna of the area, which is also most important livelihood resource for communities live there. So the 7 partner organizations that we work with are led by women who are in different occupations as forest produce collectors, or as salt pan workers, as agriculture labor, or women farmers. They look at the 4 core areas of their basic rights. They are their right to food, their right to work, health, education, and social security, and most importantly, violence-free society for women and girls. These are core areas of the organization ANANDI works with. Our mission is to promote women and young girls' leadership to be able to change to bring change for women in society and vulnerable people in the community, and work towards social justice, sustainable development, and governance which is accountable. In the kind of political scenario that we are in, fraternity amongst communities becomes an important goal for us, and we also work towards that. Our approaches, as mentioned here, are basically to the strength is in the collectives, and so building collectives, building leadership to strengthen collectives, organizing them for improvement in the kind of living conditions that they are in, and working towards sustainable livelihoods. That has been that continues to be our strategy. The approach of empowerment and rights of people is central in our work, because we recognize that the marginalization is due to the kind of inequities that prevail in society, the inequities are socio-cultural, political in most societies that ANANDI works in. And to work towards sustainable development requires that the condition and situation of women both change together for them. In order to be able to do this, I think the power of information and information of people as power for in their process of empowerment has been our key action point, and that's how we understand that community data becomes important. So community data comes from their information and how they use this information. So and the data that comes from community should become of their own. They should own it, and they should have control over this information, and they should be able to decide when and how and where should this data be used. In the process of doing of building the data and using the data for change, women and girls who are part of this process experience the empowerment. The lived experience of empowerment happens in this process. So in last 25 years of ANANDI's work, we have developed several tools and processes which are based on the principles of participatory action learning systems that facilitate both empowerment and accountability principles in collecting and using this data. The data that is captured is to enable panchayats, the gram panchayats I just mentioned about, the local self-government, to be able to improve their functions. And this data is also useful for advocacy with the state for strategic change that needs to happen on different development goals. In this presentation, I am going to largely talk about the data that ANANDI and community organizations and the community leaders have gathered together to improve the public health system and the nutrition services in the community that come from the state. These are universal programs in India. There's a universal healthcare system, as well as we have a universal nutrition support and maternal health support program, a very big program, integrated child development services. So the participatory action learning systems and the tools developed are used in order to collect data with the community, from community, and this data is then used at several community level organizations, as well as the organizations which are the governance, the local self-government and the duty bearers, the bureaucrats or the administration looking after implementing these programs. Briefly about how these tools are developed, what we call Bhaneli Ganeli. It's a Gujarati term which literally means literate and wise. Pair of literate and wise women together try to understand issues and try to capture data together on the two aspects I just mentioned, and they together developed different indicators. These indicators are basically around services for maternal health as part of the antenatal care services or postnatal care services, or vaccination for children, or services under the ICDS, which includes supplementary nutrition support, take-home ration for children, health education for young girls, women, and children in this program. In last 12 years in India, communitization of health has been and has resulted because of a lot of people's action around People's Health Assembly, the larger campaign for people's right to health. And as a result of that, Village Health and Nutrition Day has become one of the services which is a universal service again in pan-India. Every state of India has this service provided in all villages, in all urban habitats. Ensuring that these services reach in time, they are of good quality, and they are free of cost is something that most community-based organizations have seen as a monitoring action, as well as in building their collective strength. So the tool that the indicators and the tools that get developed are based on the process that are on your screen right now. This is a process of, it begins with, it's a cyclic process, as we all understand, a participatory learning pedagogy based on learning, analyzing based on our lived experience, using this analysis for the next level of planning, using the plan to take an action collectively, looking at the issues that impact them and the area where they are based, reflecting on this, and then that again the cycle begins with learning from the reflections. So this process happens from the micro level of the women's collective at the village level to the next level of community-based workers, to the next level of the coordinator in that area. And the process then goes back to that the process then results into a kind of tool which is which again goes back to the community, from coordinator to the community worker to the community leader. Okay, so these are key aspects of our community research process, where we understand that recognizing experience and practice that is there in the community is important in building knowledge. Building accountability in the community based on the solidarity group and their action and their collaboration across areas, across age groups, is an important aspect of this process. Combining, I mean, when one talks about health and nutrition, it also connects to the other human rights, such as the right to food or right to work, which are social indicators of good health and wellness, and therefore some of these aspects also get built in the tool. And then this is then taken to the next level of building skills for collecting data at the community level, which are of this nature. I will move on to the last slide of my presentation, where we are saying that as you see in the cycle, the data generation of data is a continuous process. So it is not a one-time exercise. It moves on to the next level of data when it comes to advocating for it with the local self-government, maybe if they have to advocate, make lobbying advocacy actions at the block or district level, and the next level of data is collected. So this continues to happen, and it happens when there are strong collectives of the community where the work is. So to look at the outcome of improved health and nutrition services, it is important that strong organizations who own the data, who build the data, and who advocate for their right is a cyclic process. So this is, at the moment, I would like to end my presentation with this slide. Over to you, Angela.
Thank you so much, Neeta. That was a great presentation. I think, you know, giving everyone some insights about the role of organizing and hello, sorry, I'm struggling with the technology here. So Neeta's presentation has given us some great insights about the role of ANANDI to help in organizing collectives and reinforcing that there is the collection of data is not a one-time process. It's a continuous cyclical process. I think these are themes that we're going to hear again touched upon by Vincent and Walter in his presentation. So like I said, those that have joined the session, feel free to ask any questions at any time in the chat. And we'll move on to Vincent's presentation about his work with GOAL in Uganda. So Vincent led GOAL Uganda's accountability and people-centered advocacy work for health up until last December. And in this role, he supported a network of 400 community advocates to design their own processes for collecting data, agree on what they wanted to do advocacy work on across multiple levels of governance in Uganda. So I am going to turn it over to Vincent, and I hope Neeta, because you shared the screen, you can continue to do the move the slides.
Yeah.
Thank
Yes,
you.
sir.
Great, so over to you, Vincent.
Thank you, Angela. Thank you for the intro, and I just want to share some of the experiences we had, particularly from implementing a robust approach to citizen-led advocacy called people-centered advocacy, and this was done in Uganda, particularly at district or sub-national level, and the intervention was led through a project called Accountability Can Transform Health. And we were largely reaching out to about 400 community advocates representing about 18 districts in Uganda. And these were particularly the ones that were leading the strategy and the engagement at community level. People-centered advocacy is a common buzzword in the accountability circles, and part of what we had to do at the beginning is to try and customize what we know about people-centered advocacy with what we actually stood for as principles and values for what we wanted to see community happening in the community. So we came up with a definition that would enable us to bring out these unique attributes. And what we have as a definition that united us was that people-centered advocacy is a systematic process owned and led by those affected by an issue, using evidence to influence people with power at different levels to make sustainable change in practices, policies, norms, and values for the betterment of those affected. And this was an iterative process. It wasn't a one-way process. And that's why you see that our experience with monitoring, citizen monitoring that was happening to empower this approach wasn't a one-off. So there was quite a number of turns when community kept collecting data that would enable them to empower or prove the magnitude or the change that they were looking for at community level in their respective health centers. So the people-centered advocacy process, if you look on the right side of the slide, has quite a number of processes that we go through to prepare the community to engage effectively. And I particularly hit on the places where continuous collection and a collection of data through monitoring and analysis, and then eventually monitoring happening. The places that I wanted to highlight for us as the key places where we actually actively see communities collecting evidence, choosing which kind of evidence they want to put across to decision makers to ensure that their issue is understood not just from a problem perspective, but also with the magnitude that it has. And when they collect the data from the community, from their respective health facilities, they come back and have an opportunity to analyze this data. We call the process making sense of the data collected, and this is done in a participatory way. And then once they have the data analyzed, then they're able to make statements for advocacy that they would use to petition different audiences. Now, at the very end of the process, you will also see that there is a continuous process of monitoring and checking on the changes that are happening at their community level. And this is empowered through their plans. Next slide, please. So this slide is basically intended to give us a sense of what are the real or the major differences that exist between research about affected communities and research owned and led by affected communities, basically with main considerations going to who sets the research agenda, what methodology do they use, how is the ownership of data and the analysis of data or making sense of the data and what's the goal of the research process and whose voice is prioritized. And quickly through my presentation, you can see that the extreme sides where the extreme side is, the side on your extreme right is where the community, the PCA approach fits, the people-centered approach fits there, where communities affected by an issue are taking center stage in deciding the research agenda or the evidence collection agenda. They also they follow a relatively simple and methodology, and they are driven by the need to prove the magnitude of the problem to their decision makers or their duty bearers at district level. In terms of ownership of data, again, the ownership is more with the affected communities. And yet on the flip side, you would see that more of the research data is owned by the research lead and the CSOs. When it comes to the analysis of making data sense from the data, communities lead the analysis and they make sense of their data. And it doesn't matter how long the process of enabling them to do that takes, but at least we aim that at the end of it, when they can actually make out some meaning out of this data, then that's something that they own and they will use it for their engagement. And then lastly, citizens use their evidence to directly push for reforms while building citizen competences for evidence-based engagement. So we expect that this is an empowering process for them as well. Next slide, please. Yeah, thank you. So the next slide particularly helps us to share the experience of Patricia Odongo, a community advocate from Tororo district in Uganda, who shares her part of the experience doing people-centered advocacy, mainly bringing out the experiences that she had with data collection, the petitioning, and the monitoring of commitments of duty bearers in her district. And just a quick read from Patricia's story. Patricia is just one voice of the 400 that were working in the 18 districts to do this kind of work. And Patricia was saying, when I was selected as a community advocate, at first I was worried if I would be able to represent the community. When we first went to the health center, we asked for documents like the supervision book, even though we didn't know what the documents should even look like. When we went to the technical people, they would dodge around, and the district officials asked us what our qualifications were. And Patricia questioned, if I have a problem, does it matter if I have a qualification? If I don't have training, does it matter? Because I am suffering. And once district officials told us, our letter was misplaced, so we gave them other copies, and Patricia goes on and tells her story. But ultimately she concludes and says that I cannot ask them what they did, but we are seeing changes. And even last week, we took messages of appreciation, but asking for more. In other words, they were pushing for more reforms besides the ones they initially put across. Next slide, please. This slide particularly helps us to see how do you get a person like Patricia, who is not quite, who is not your basic professional researcher, but a lay community person, pushing for an issue that affects them directly. How do they go about this? So the process of preparing them involved a lot of training for them, but it was more of training and action. And this slide shows us what kind of evidence were they looking for. And before us is the kind of tool they used in the districts where they found themselves as health work absenteeism was their biggest issue to address through advocacy. And you can see that a lot of the questions that they're asking are things that relate to what would help them to prove the magnitude of the problem. like the name of the health worker. And the beauty of this evidence from the community advocates was that besides just telling us absenteeism is a problem to this magnitude, every row that you see after here should be covered by a name of a health worker. So what you would get at the end of the day is a list of health workers with their time when they came and when they departed. And this would go on for some health facilities for a period of almost 30 days, health workers monitoring and checking who worked and who didn't work and the reasons why they worked. And if you look in the side questions, you can appreciate that they were asking questions like how many of the health center staff are having other jobs, because this is a common reality in Uganda, that a health worker will be assigned to a health facility, but they also do another piece of their time in a private facility or in a private health clinic or drug shop which belongs to them. And this usually happens at the same time they're supposed to be working in the government facility. So these are the questions that they were looking for and asking themselves, if we presented these questions, if we got data that would prove that these questions, at the depth of these questions, then it would be easier for them to put a case before the decision makers at district level to prove the case of absenteeism as a problem. If you move to the next slide, Neeta. The next slide basically gives us a sense of what the analysis process gives us. If you look at the drawing or the picture inside of the presentation, you will see that about 5 health facilities within a particular district where collected data. They had data collected from about 5 health facilities, and these 5 health facilities are represented by roughly about 5 community advocates in each of them, and these used to go to the facility on a regular basis. In this case, for Omoro district, they went for 14 days, monitoring and checking how many health workers worked today, how many health workers were absent, what were the reasons for absence, were they absent because they were on leave, official leave, or they were not on official leave, how many health workers are accommodated at the facility, because accommodation has a bearing on how staff come early or late for duty, because if they are commuting from far, that makes it difficult for them to be on time when they are reporting for work. And so basically that diagram gives us a snapshot of what a lot of work that the community advocates will have done collecting ends up into in terms of the summary. And for instance, the first health facility that you see up there has about 16 health workers. This is a health center 3 in the Ugandan context. A health center 3 is supposed to have about 18 staff. So 16 is not too bad from 18. But if you look at the work that they did over the 14 days, you realize that actually there were more working days, staff working days that the staff members missed to be on duty, because the ultimate time that the staff time that should be seen ultimately when the health workers come regularly on duty would be 224, but you realize that they could only achieve 84, leaving a deficit of about 140 staff days. And that would give you about 65% absenteeism as a level for that particular facility. And when you look deep into this particular writing that the community did, they came up with a whole sum for the district showing that absenteeism stood at 61%, for instance. And that's what they captured, and they would put this in a statement like the one you see on the extreme right, which would then be the petition that they would write to their duty bearers, particularly bringing out the extent of the absenteeism showing the time that people arrive and leave work. For instance, in the Lira case where you have this excerpt, health workers are supposed to arrive at 8 in the morning and leave at around 5 o'clock in the evening. And 10:30 was the time of coming. And for community, they are so particular that it is 10:34 and not just 10:30. And the leaving time was 4:23 p.m. And this, for them, was the reason why people were waiting for long hours to get treatment, and some actually miss treatment. Neeta, next slide, please. And so, based on the evidence that community collected and analyzed, what we saw on the flip side when they began to engage with the decision makers, we realized that community advocates' intensive monitoring in health facilities provides more realistic data than sporadic government supervision visits and staff record books. Most of these records are usually prone to abuse, like the attendance book can be signed in advance or before, depending. So, and these are the tools that government depends on to analyze absenteeism. But when community took their time to do this for 14 days, they found a different picture. And this was quite challenging and surprising for the local authorities. The extensive detail made it clear to government officials that the advocacy petitions were backed by significant monitoring efforts by the community advocates. Like I mentioned to you, when they are collecting the data, they don't collect lump sums only. They go to the specifics and look at every staff member in that facility and when they arrived at the health facility and when they left the health facility. And they make an analysis that would work for almost 14 days, probably longer than any absenteeism study has done. And this helps them to have a more concrete picture of what absenteeism looked like at their facility or late coming looked like. And the process of gathering their own evidence instilled confidence and propelled advocates' campaigns. This was seen in all the 14 districts where absenteeism was a big issue in the advocacy campaigns at district level. And communities got a lot of, the community advocates gathered a lot of momentum for their campaigns, as you will see eventually in the analysis of how responsiveness worked from the decision makers. In the same light, because this was a process that enabled them to pick confidence and build essential skills for engagement, in 7 districts, advocates identified additional issues that they wanted to engage about, and they collected data for it and made it available for decision makers to engage again. I'll go to my last slide, which is more of a visual, just to show you the trend of responsiveness that happened when communities were engaging with evidence. When you look at the red mark, this really out of the 18 represents the local governments, the districts, where officials largely were unresponsive. But from the yellow side, from the yellow bar, you can see that government officials made commitments, although they were quite limited in terms of their implementation. But when you appreciate further and see the green bar, we see that government officials in 5 districts actually implemented the commitments that they made as far as the issues that were presented to them. And we saw in 3 districts, government officials even implementing actions beyond the campaign commitments. And this all, in a nutshell, speaks strongly about the power of monitoring health services at community level, but using an evidence-based approach to engage seemed to show a bigger difference. Thank you very much for listening to me.
Great. Thank you so much, Vincent, for sharing your experience working with community advocates in Uganda. I think there's some similarities to the strategy that Neeta described from ANANDI of organizing community members to do advocacy, and also highlighting the importance of the analysis of the data collected by citizens, collected by community members, and the ability to use that to advance an advocacy agenda is very, very vital. There's a strong relationship between the collection of data, the analysis of data, and the use of that data for engaging duty bearers and power holders. So we're going to move on to our final presentation in the first section from Walter Flores, who was the former executive director of the Center for the Study of Equity and Governance in Health Systems in Guatemala. So Walter has also researched, taught, and consulted in more than 30 countries of Latin America, Africa, Asia, and Europe. But he's going to speak in some depth today about the work of the Network of Health Rights Defenders in Guatemala. Over to you, Walter.
Yes, great. Thank you. If you can move to the next slide, please. Okay, so in terms of the Guatemalan context, 40% of the population is indigenous. And here is where the worst social and economic indicators you can identify. And there are many barriers that indigenous people face to access not only health services, but also education. And all of these have impact on the quality of life. And as you can imagine, the systemic exclusion of indigenous population is really a structural problem that comes from colonial times that after several centuries has created unequal power relations. And as in many other countries around the world, whenever we work with marginalized populations, we identified that they do not only face barriers to the services, but also there are many concerns or issues related to the lived experiences that public services do not take into account. For instance, research that we have done in Guatemala, but also some other colleagues have identified that in addition to distance or language barriers, indigenous people do not attend facilities because they are usually the victims of abuses by providers. For instance, demanding illegal payments for receiving services, being treated without any respect, being discriminated against just for being indigenous women or having a low educational level. So all of this creates different additional barriers that a lot of populations do not come to the services. So there's a lot of research showing that, but again, as in many countries, authorities do not really do much about it. They don't really care much about marginalized populations. So in the year 2002, in 2004, there were two very important changes that happened in the Guatemalan context. The first one was a new decentralization law that was transferring the responsibilities to the municipal level for resource allocation, for monitoring and planning. And the second one, which is 2 years after that, was a new health act that, in line with the political constitution of Guatemala, recognized the right to health, but also the right to participate in public businesses. And that meant that anyone in Guatemala has the right and the obligation, as the law says, to participate in the planning, monitoring, and evaluation of public services, including healthcare services. So with that change in the context, my organization started with some grassroots organization to use those two changes into law and trying to see the possibilities of promoting the participation of indigenous communities into the planning monitoring services, so those services could respond to their needs. And also we wanted to identify whether collective action was also possible to be implemented to use those two new laws to make healthcare services more responsive to communities. The next slide, please. So as you can as all of us know, monitoring systems, health information systems in most countries only collects information about service delivery. They do not collect information about the services that are not being delivered, either because people are not coming or for any other reason, and even less so collect information about whether people are being demanding illegal payments, whether people are being treated with respect, whether there has been discrimination, or any of these problems that affect people's dignity as well. So what we did is that instead of replicating a government-led monitoring system and health information system, we developed together with community a system, a monitoring system that was meaningful for citizens, for users of services. And that is a monitoring system that leads to accountability. And what it means in summary, a monitoring system led by accountability means an independent and autonomous citizen action. It means that it's not controlled or influenced by Ministry of Health or by the municipal government. It is totally independent and autonomous and controlled by user of services. The second one is that it relies on the legal framework, because it's very important for any of these systems to work, that we use what the legal framework states in terms of entitlements and in terms of rights as well. The third characteristic is that it's very important to implement rights literacy campaigns, because as we are saying, it's important the collective action in any citizen-led accountability. So as many people as possible should be informed about the rights, what is expected, what they should expect from public services. So many of them, or most of them, can become active citizens monitoring healthcare services. And the third one, the fourth one, which is a very important one, is that all of these citizens that will do the monitoring, they need to develop key capacities. One is to monitor the public services, which means collecting systematic information, analyzing that information, and ensuring that that information can be verified. The second one is that that information has to be used for strategic advocacy. And for this, what we mean is that it's not writing only a report, it's not only just finishing and presenting the data, is to identify for each situation what sort of a strategy will be required to influence decision-making. For instance, in some occasions, the strategic advocacy means press conference to present data that the government is denying that is a problem occurring. Some other times involves presenting the data and seeking alliance with parliamentarians because the data is showing there have been problem with resource allocation. Some other time means community using the information to work with the Ombudsman or Human Rights Commission because the data that they collected reveals rights violations, which is an issue for Ombudsman. The next slide, please. So in this process of citizen-led accountability, the key actors are the right to health community defenders. And the next slide. And the right to health community defenders are all of them user of services, are citizens that live in those rural communities that use local services. The next slide, please. And very important, all of them are volunteers. It's people that want to improve the services for their families, for their neighbors and communities. And they do it as a volunteer because what drives them is the collective action of indigenous community wanting to improve the public services. So all of them do not receive any payment. We only provide the technical assistance and some equipment that they may need to do the monitoring, but there is no any economic retribution for the work they do. It's a total organization owned by communities and run by communities. The next slide. I think that was my yes. So in the next part, after we finish this part of questions, I'm going to show you a short video in which the community defended themselves, explain in the video what information they collect and monitor, how they use the information, and what motivates them to do the work that they do. I'll stop here. Thank you.
That's great. Thank you so much, Walter. I hope everybody can hear me. I see we do have some other members in the presentation. So if anybody has any questions or for any of the presenters, please feel free to unmute yourself if you want us to see you, and if you have a question, you can type it in the discussion or the Q&A in the on-air portal. But we'd love to have questions from anyone who's curious and interested. And as well, I think some people who joined the meeting maybe missed some of the earlier presentations. We had 3 presentations, one from Neeta Hardikar about the work of ANANDI, organizing women's collectives and monitoring health and nutrition services in India and Western India. Then we had Vincent from Uganda discussing the participatory data collection and analysis and advocacy in Uganda, and then from Walter about Guatemala. So. And also, presenters, if you have questions for each other, you're very free.
Actually, yeah. I had a question for Vincent. Vincent, you spoke about the accountability mechanism in the public health services, the hospitals. Do you in Uganda have the right to information, proactive disclosure kind of a legislation in your country? And do the community data collectors exercise that right after collecting this data?
Yes, thank you very much. Thank you very much for the question. I hope you're hearing me. I have a signal here. Great. Yeah, thank you very much for the question. Uganda has a Right to Information Act, and part of the information that community members were looking for is within their right to access and actually get to use it or analyze it in a way that they would petition different decision makers. The problem with it is that Uganda, like probably the context Walter has just mentioned in Guatemala, is that there is so much unequal power relations within the system. The citizen in your basic community in the rural area is so deprived and so disempowered that when they rise up with the data, like I shared with you for Patricia, the big questions that come as intimidation questions to basically push them off. But everyone in the decision-making arena knows that it is within their right to actually have that information. So when they went to the facility and asked for the supervision book, although they had difficulty getting it, but as far as their rights, their health rights are concerned, they are actually supposed to access that information. I hope that answers your question. Thank you. Oh, Angela has an understanding of the Ugandan context. She could throw in something to add to what I've just said. Thank you.
I think you captured it. So I don't know if there are other participants who have any questions. I mean, please feel very free. We set this up as a Zoom meeting, so anybody you can unmute yourself and ask any questions, or you can type it in the chat box if you prefer in the on-air platform. You're very welcome.
I have another small question for Walter and Vincent. Has there been, like, we see a lot of pushback from the state where they will say this data is incorrect and, where have you come? A lot of resistance, and sometimes where people, community advocates, are also individually approached and attacked and threatened. Have you seen that, and then how do you tackle it?
Yes, we have some authorities. There are pushback, of course, but we have broader strategies as a part of the strategic advocacy. We have an alliance with the National Ombudsman Office. We also have an alliance with a civil society organization that do human rights litigation. So whenever we need some legal backup, that the lawyers that litigate, we have the support of them. And also we have a collaboration and some also alliances with some progressive parliamentarians, which community defenders use. I mean, the whole idea is that they call them immediately if they feel that there is a threat or there is a pushback from authorities for the work that they do. But in addition to this, what is very important is that they are very much aware and knowledgeable about the legal framework, because that is the strongest tool that they have to confront pushback from authorities, because most authorities try to push back assuming that rural people do not know about the rights, or they don't know about the laws, and they always saying like, you don't have rights, all of that. So they always, because they are very well informed and trained on the legal framework, so that's the most important tool that they have to fight this pushing back.
Yeah, I guess the case is not so different from Uganda, in the sense that actually for the community advocates, their biggest fear was the pushback. Even from the very start, they got to know that they were going to engage. They knew they had a very cordial relationship with their health worker. For some of the problems that they saw, like absenteeism, it wasn't the first time they were seeing it. They actually had problems with absenteeism, and they were seeing how it was affecting them. So it was, becoming a community advocate was a kind of like a very delicate decision to make. So you saw in Patricia's conversation, they knew they were going to have problems with relationships at that level. And even when they engaged at the facility level, in Uganda, a health worker is a very strong power holder in the system, because we don't have as many health workers around the country. So when you stand up against a health worker, the health worker is viewed as a very important power center there. And therefore pushback is definitely expected. But what we saw is that when pushback happened, there was a way that the CSO partners then would come in to support the community members involved to have some kind of arbitration with their district. And so engaging the higher level was always the better way to deal with the pushback. And if, for instance, the district level didn't respond as well, there is also another office, which is like the Ombudsman's office, which is the IGG in Uganda. So the tire keeps growing depending on where you're getting success and pushback, and you keep engaging upwards. And where you have responsive leaders, they also come in with arbitration. so that community is reconciled with their health worker or their district officials so that there is an amicable solution. Thank you.
Thank you. Thank you.
Sejal, did you want to share anything about how you as ANANDI have tackled this?
No, I just the same things that you actually use a law framework where it helps you to define it. And one of the other things that we found effective is that for the demand for health and nutrition services is very low in marginalized communities. So there is some interest even in the state because we have very poor social development indicators. So they're also getting to meet their targets. So if you're able to, there is an initial resistance, but if you're able to show that actually reporting better on malnutrition actually will solve the problem eventually, then in the offtake of services improves if people are more approaching the health services. And then what we do is that during epidemics, or like for COVID right now, and we've had others earlier, other epidemics, we report on every child in maternal death, and they're supposed to do an audit, but often the data doesn't get to them. So sometimes it's the lower level health workers who would like us to say this, because then they know that when they say it, their system will come down on them, that don't report all this data because it will show us in a bad light. And sometimes it might be the higher level officials who want a greater offtake. So we do collaborate on some things because we are a community-based organization. So we do help outreach them in epidemics and other services where people are difficult to convince. So it really, but it's there is no linear progress. I can't say that things improve. Sometimes, after 5 years, things might really deteriorate. You will have standoffs. But therefore, for us, the larger community collective is actually the one that sustains. So for us, that organizing is very critical to this. Otherwise, individuals get targeted all the time.
Right. Yeah, there's this relationship between, okay, how do you, for those community members, collectives, cooperatives, individuals that are interested in engaging with the state in this way, how can we prepare them as civil society actors to engage with the state, knowing that they will get pushback? And they know this better than we do even. They experience it all the time. So what tools do they have to prepare for that when it happens? And then what are the broader systems and broader approaches, like working with more sympathetic health workers and an alliance, or sympathetic local politicians? I think these community advocates, in the case of Uganda in particular, and to the extent that I know the work in Guatemala, there's multiple strategies to prevent and then mitigate negative reactions from the state, because you might have some good government officials who really appreciate the work of health rights defenders or collectives. And so how can you use those positive actors in government as your allies to defend you from attack by whether it's health workers or other local officials? So these are very complex relational questions. I don't know if anybody.
One last observation
Yes.
I'd like to make, that I can see that both Walter and Vincent, and our experience is also that this is a longer term investment, and you can't do this 1-year projects.
Yeah.
People ask you to do a 1-year project and get results, and I find that so strange because that's really putting communities and people at risk. So you need a longer term investment is what I am hearing from everybody.
Absolutely. I think everybody would agree with that.
Yeah.
Totally agree. Yeah.
So there's a few other participants. I don't know if anybody else has any questions, or if not, we can move into the next phase. Walter has a great video to share. And then we're going to go into a little more depth on some of the tools that ANANDI have used and that Vincent has used in Uganda. Oh, I see a question. from Fernanda. How do you plan the training of the community? So I would open that to any of the presenters.
I'm going to start. Yeah. Okay. So we have two different kind of training. The training which is like the basic training that every community defender has to go through, which is the basic about the law, legal framework, the basic on public policy, planning, monitoring. So everybody goes through it. But then there is additional training based on the issues they are interested on to monitor, and also specific issues on context. For instance, some provinces, the specific issue that they face is a geographical access that the barriers increases during winter, for instance. So for them, there's a training about specific issues, the what to do on that period of the year, but also how to monitor and resolve issues of emergency due to natural disasters and all of that. So that's specific training for them. And some other communities in other provinces will have another specific training. So there is also ad hoc training based on what is the issue that they are monitoring at the moment, and also anything that may come up as relevant for the work. I'll stop here.
Yeah, thank you. I will just add to Walter's submission. In our context in Uganda, I think the training took two ways. We were doing an approach called people-centered advocacy, which by and large is not the popular way advocacy happens in Uganda. It happens more CSO-led, and you find more research think tanks and bigger organizations leading the advocacy process. So the evidence collection is their research project, and the issue comes out, and then you eventually see the affected person almost like an accompaniment of the process. They only follow, but they have not so much to do with the process. And part of what we had to deal with is we had to first deal with the NGO staff that we are working with to have a totally changed mindset about how to empower or how to build the capacity of vulnerable people to speak up for themselves. And this had to take us a process of, more like conscientizing the NGO workers that there is a new way that we can do advocacy where we don't have to make the decision. We don't have to call the shots. And then we also then designed a training package, and this was really built around a PCA guide that we developed for this purpose. And this was intended to take the community through a journey. How would they make their advocacy campaign strategy for the district? And so they would do trainings, let's say like breakaway sessions. They do a training and then break away for a month and do practical things about what they learned. And then they come back for the following session and do something, and then they go back and practice. And so doing that with them along the way looked like a long time of engaging with the community. But we kind of think that the reason why we saw a lot of commitment and determination to push on with the decision makers even when backlash happened was partly because this process was well understood by the community. And this is so different from the Ugandan context in the sense that I've been in a workshop where we are trained to do advocacy, and it's a 4-day workshop, and everyone thinks that at the end of the 4 days you're good to go for the advocacy process. But then you can't leave a marginalized, vulnerable person in that state. You need to capacitate them. And when you look at the structure we did for the support, every officer that was working with a group had to have a support plan that would enable them to interact with the community, asking them, how do you need me to support you? Rather than do this, do that, because again, it kills the ownership and the dynamics of power, destroy the beauty of what we were looking for. So that's how we engage with them. And when you look at the management guide that we have for the training, it takes you through phases of training. It's not a one-off. Thank you.
Yeah, so some of the things what Walter and Vincent said are also kind of practiced in terms of training the team which goes for the data collection, community data collection process. But the training happens at several levels. For example, in campaigns where we have student volunteers, there are trainings which really happen at a very basic level on understanding constitutional rights, understanding rights within the health programs, rights within the nutrition services programs, monitoring the roles and responsibility of each duty bearer. So these are basic technical training that happen. There are some trainings which are based on other participatory tools, including folk forms, folk songs and drama that one uses. So some trainings happen around that. But most importantly, once the data comes to the community, how do you use this data in the community back is an important aspect of training. And so the data collection team as well as community leaders together, how will they present? That is also an important training process that happens in Anandi's case. Once this data, so there is one strategy that is used for presenting it at a level in the village where probably few people read, but there is also, this data is also then converted into a format which is more validated by the state when it comes on a piece of paper. So same data is converted in such a way that the state also accepts. So training of the data collection team in both report cards, both kind of report cards is another important training for us. Yeah. Thank you.
Great. I mean, I think what comes through clearly in all of those examples is that, yes, there is an initial investment in basic training or understanding of how the systems work, what the health system should be doing, what the roles and responsibilities and mandates are within the government systems. But then there is an element of ongoing accompaniment and support, partly to protect against backlash, but also to keep building that skill set and keep building the knowledge among citizen researchers about how they can, you know, most effectively tackle the specific issues that they are prioritizing, because the technical elements are different if you're talking about accessing nutrition services versus you know, other kinds of problems that advocates or citizens might be working on or using their data for. So I see a lot of new people have joined this meeting. So I'm going to suggest that we start the second part, which is looking at some of the more specific tools that have been used in Guatemala and in Uganda and in India. So we're going to start with a brief video from Walter, and then we will go back to Neeta and Vincent. So again, really open to anyone to ask questions in the discussion on the on-air platform, and we can come back to them at the end of these three brief presentations. So I'm going to go ahead and share the video for you, Walter. Hopefully I can do it. I won't have the, so everybody just hopefully bear with me. Share sound, share.
Great, yeah.
Great, I'm going to hit play.
Los servicios públicos de salud son muy importantes para nosotras y nuestras familias, pero a veces al llegar a los servicios nos encontramos con problemas, no hay medicinas o vacunas o están cerrados. Otras veces nos enfrentamos al personal en los servicios que nos discriminan por ser indígenas, campesinos o mujeres. Y también existen algunos casos en que ante una gravedad médica familiar que necesita traslado a un hospital, las autoridades de salud nos obligan a pagar por combustibles y no nos dan comprobantes. Entonces, nunca sabemos si en verdad se utiliza para eso. Y hay muchas familias que no pueden pagar el dinero que les exigen y que se quedan en sus comunidades sin recibir atención. A través de talleres y capacitaciones hemos aprendido que otros problemas y situaciones violan nuestros derechos, de que no debemos aceptar ser discriminados, que los servicios de salud tienen responsabilidades y obligaciones hacia las comunidades, de que los cobros por servicios públicos es corrupción. Para cambiar la realidad de los servicios públicos, estamos actuando como defensoras y defensores comunitarios por el derecho a la salud. Todas y todos somos voluntarios, electos por nuestras propias comunidades para educar la población sobre sus derechos y obligaciones en relación a la salud y a lo que le corresponde a los servicios públicos, recoger evidencia de los problemas que los usuarios enfrentan en los servicios públicos, defender a los usuarios cuando existen una violación a su derecho, como la falta de transporte, la exigencia de cobros, dialogar con las autoridades y planes de acción conjunto para resolver los problemas, apoyar a los servicios locales de salud para que el nivel central los asignen mejores recursos para atender a las comunidades rurales del país. Somos más de 160 defensoras y defensores presentes en 35 municipios del país que pertenecen a los departamentos de Huehuetenango, Quiché, Totonicapán, Sololá y Alta Verapaz. Como defensoras y defensores buscamos continuar con el diálogo y trabajo conjunto con los servicios locales de salud para poder resolver los problemas estructurales que afectan el acceso a los servicios de la población. Nosotros pensamos que si logramos resolver los problemas estructurales, todas las comunidades rurales se van a beneficiar, aun aquellas donde no existen defensoras o defensores comunitarios. Entonces, nuestra meta es nuestro compromiso y trabajo voluntario beneficia a la mayor cantidad de la población posible. También estamos forjando colaboración con otras organizaciones del Estado, como la Procuraduría de Derechos Humanos, para solucionar los problemas y defender nuestros derechos en una forma integral.
We can stop it there. It's just it's not.
Great. Sometimes a picture is worth 1,000 words. So that was a beautiful video from Walter. And I believe that video is available on the CEGSS website. So if anybody wants to watch it again, at the end of this presentation, there's going to be a hyperlink to the CEGSS website. So I think the next step is if Neeta, if you could pull the main presentation back up so you can talk through one of the tools that you've used for supporting citizen-led research in India, in Gujarat.
Should I share the slides?
Yes, please.
Okay, thank you.
And for all the participants that have joined us, you're welcome at any time to ask any question in the on-air platform, and we will come back to it after these two brief presentations from Neeta and Vincent. So don't be shy.
Okay, so we in the first section, I'm going to make this full slide. So you can see one, can you see my slide?
Yes. Yes, Neeta, we see your slide.
Okay.
Put it in full screen.
So sorry. Yeah, I think this is now full slide.
Not yet.
Not yet. Okay. Is it now? Is it full slide now for you?
Yep.
Okay. So as mentioned in the first part of our presentation, we were saying that there are other social indicators which are important for protecting right to health and nutritional food security. And by this tool, what we try to establish is, if you can see the center of the image is a storage bin for grains. And you can also see some of the maize seeds at the bottom of the storage bin. This is an indicator. The storage bin with full seeds is a symbol of prosperity or wellness in the family. The two arrows on the left is an arrow showing income coming from a male member's labor or work. On the right side, there are arrows that show income from the labor or work of the woman member of the family. And we do this at this tool is used at the household level to see what kind of work the family is involved in, because work is connected to food security, and that's again, food security is linked to overall health and wellness in the family. So in this exercise, every person, every woman for her household tries to say what are her sources of income and what are the sources of income from the family. The holes on the bin actually show the expenditure, and these vary for every household. In our in almost all the household based mapping of the food security and overall well-being in the family, we have seen that the highest expenditure goes into in health expenses. Gujarat is also among the states where the state report shows that it is one of the states where highest out-of-pocket expenditure is recorded. So this shows that probably the expenditure on private health services is higher because there are either lack of services at the primary health center, or the service quality is not of good, or is not good. Or thirdly, as Vincent said, probably the health staff that is supposed to provide the service is not available. So to arrive at that, the arrows in the center, what you see are the arrows showing the entitlements from different schemes that are available for every household. These are universal rights for food ration, food grains from the public distribution system that is available, that is there in India. There are entitlement under the health services for free health services at the primary health center, or vaccination for children from the ICDS, the Integrated Child Development Program, or the take-home ration or the hot cooked meals from the centers for children, Anganwadi centers for children in every village, or the midday meals in the school. So these are some of the few the entitlements I'm listing, but there are maternity entitlements, there are cash services for person who's being treated for tuberculosis. There are pension scheme for person with disability. All these entitlements technically should come to this to this bin, which is a symbol of availability of resources from labor and availability of entitlement from government schemes. This kind of brings to the information to the group that how many households have what kind of entitlements, and how these inaccessibility of these entitlements lead to larger holes in the income and labor of the family. This is a participatory tool. It changes with every household. There is no need for any other tool. Maybe a chalk stick, a floor, a chart paper with pen are enough for facilitating such a discussion. And this brings a very concrete data, which you can see on the screen for the labor that goes in from woman's side and what kind of income she brings in because of the unpaid work that she does or the care work she does at home, and the kind of labor or income that the man brings in the family. So there's a gender disaggregated information also that comes from this tool. This tool is then, the information from this tool and other tools is then presented in different forms. The picture on the left side shows information of children in the family who are either stunted or they are severely malnourished or are in good, they have good health indicators. So these are written up on the wall in different colors for non-literate women to follow how the children is faring after she accesses services from the Anganwadi, the children's center, the ICDS centers. She's able to then monitor how her child in the previous months or 2 months ago was probably in the red grade is now moving to green grade. When the data sharing happens in the community, these are some of the folk forms for mobilizing people to come to a Gram Sabha or a meeting to understand and learn about the data. This is done through campaigns to mobilize people and come to the Gram Sabha. The third way of presenting the data is here, where in the Gram Sabha, where women and the Gram Panchayat members, I mentioned about the local self-government at every village level, the elected body. Actually, the president of that body chairs this meeting, which happens every 3 months. And in every 3 months meeting, there is health is an important agenda where the discussion happens. The local duty bearers of the at the community level, the service provider at the community level, presents her data. At the same time, the community groups, community-based organization groups also present their data in the format which is on the left of the slide here. These indicators are shortlisted. I mentioned in my previous presentation that 200 odd indicators are identified, of which key 10 to 15 indicators are shortlisted by the community-based organization, saying that in our village we want to focus on this particular indicator. So, for example, each of the indicator is also has an icon. Did they get emergency health ambulance services on time from government hospital in the village in the last 3 months, and for how many pregnant women, and if that was not available, did they have to use any private services? So those kind of indicators are mentioned here. This data is presented in every 3 months, in the Gram Sabha every 3 months. In last 1 year, actually because of COVID, no Gram Sabha happened, so no report card was presented. But community continued to monitor public health services, unable to present the data in the Gram Sabha, but the data is collected by using these tools. Yeah, so this is from my end here. Should I move to the next one for Walter?
Yes, actually the next one's for going back to Vincent.
Okay.
And just to remind everyone, please put any questions you have in the discussion in the on-air platform. That's the easiest way, so I make sure I don't miss any of them. Okay, Vincent.
Okay. Thank you, Angela. The tool that I'm sharing with you builds from the approach that I just shared first, which is the people-centered advocacy approach that we implemented in Uganda, particularly giving the power to advocate and to engage with decision makers, to the vulnerable, marginalized community members who have a first-hand experience of what a failing health system means, or come face-to-face with the problems that would relate to any failures within their health service delivery. When we finish the process of engaging with them so they have a well-developed advocacy strategy for their district, the next step that they come to is the process of engaging with different decision makers, either at the health facility level or the sub-county level or at the subnational district level, particularly with their district health officer or any other members within the decision-making hierarchy. And what usually happens is that when the community has built a body of evidence and have generated a petition for a particular duty bearer, let's say a district health officer or a chief administrative officer, what happens is that they take note of one critical thing at the engagement point, and that's the commitment. Once they petition, they will do everything to ensure that they seek a commitment or a pledge for action from that particular decision maker. And so the tool that we have here, which is the commitment log, thank you. The tool that we have here, which we call the commitment log, is something that we developed together with the community members, particularly asking ourselves the big questions. What happens if we've finished petitioning? Is that the end of the advocacy campaign? Is that all that we are going to do to see the change that we want to see? And the big answer that came from them was definitely not. The pledge is a pledge, but it has to meet with action for it to be honored. And so we worked with the community and came up with the commitment log, which is your basic tool to help capture all forms of commitment that are made by the target audiences that community advocates have engaged. And the tool will specify actions taken by the community advocates to engage a given target audience. And we have an example of the different target audiences that they engaged in Uganda. And I'll take you just through one line to give you a real feel of what that is like. The tool that they develop, which is the commitment log, helps them to track the commitments made towards the advocacy asks. Remember, every duty bearer that the community advocates made had a specific set of asks that they put across to them based on their mandate. For instance, if they were meeting their district health officer, who is the overall duty bearer concerning the issues of health in the district, their set of asks were in tune with what the duties and the mandate of the DHO are. And we did this in the training processes to sensitize them and bring them to a place where they appreciate that not all district officials do the same kind of work. They do different roles, and these are the roles that they do. And based on this role, the DHO or the district health officer can do this or may not do a particular set of asks that you're giving them. So that's well digested at community level. Then it became easier for them to have this commitment log operationalized at their respective district level, where they would constantly engage and track and pick a pledge, pick a commitment. If they have engaged a particular audience and they have not got a commitment from them, the community advocates would still count that meeting as not finished, because the ultimate desire or end that they wanted at the point of petitioning was a commitment, because it is with the commitment that they would continue to follow up with the particular decision maker. And so a brief look through the commitment log. If you look at, for instance, the examples we have in there, the commitments that were, the engagement that happened on the 16th of March in 2017 was a meeting that was done for the Chief Administrative Officer. And the Chief Administrative Officer committed to come and meet the community advocates in their respective places that they could follow up with the issues that were raised to him. And they asked for a time frame, and he committed that this will be done in 2 weeks from the time they met with him. And so in the tool, they asked themselves, what shall we do to follow up this commitment? And they said, we will do a physical follow-up, and this will be done with the cow to see that he fulfills his commitment. And they even schedule themselves to when they will follow up. And this doesn't end until at the end of the line, at the status of the commitment, they have a statement that says it is achieved. As long as it is not achieved, they come back on every monthly review meeting as a team of community advocates to review their commitment log and say, what is it that we were able to achieve as a commitment? What was it that we didn't achieve in the period that we are reviewing? And based on those, they would then discuss on how else do we navigate the system to get a commitment for this, or to get this commitment achieved. And this might take re-strategizing, choosing another secondary audience that could influence the district chief administrative officer to make this commitment achieved. And so you see that through this, this tool provided a guided approach for them to actually be able to tell their own success, whether they have been able to see a fulfilled commitment, and they would close the action at the point when they see that a commitment has been fulfilled. Once it is not fulfilled, then that means it is more work to do in the monthly review meetings as community advocates from all over the district, looking at what ways they can re-engage and engage again, using secondary audiences, using allies in the system. We had unique examples in our process where relationships that some of the community advocates had with some of the duty bearers or secondary audiences were utilized in that way to ensure that there is action achieved at the end. So it facilitated the iterative process of engaging, checking on the monitoring information and seeing whether they are getting there, and then repositioning or deciding how to reposition or re-strategize based on the reality or the experience or the fulfillment of these commitments. Angela, I think that summarizes it. Thank you.
Excellent. Thanks, Neeta and Vincent, for those presentations. And definitely, I'm just opening it up now to any questions anybody has about any of these tools. I mean, we have about 15 minutes for wrapping up. And I think across all of these examples, we see some consistencies here in supporting citizen-led research, that this is not a process of training community members to be enumerators for formal research projects. That's not the ethos or the principle underlying citizen-led research. The principle here that I think has been illustrated by all of our presenters is that this is about letting community members and people affected by these issues really say what their priorities are, and helping them to understand the government systems, how they're supposed to work, and how they, as citizens, can use that knowledge and gather data, gather evidence from households, from communities, from health facilities, from government services, and use that for action. And this is the thing about action research. Action research is not so much tool-led, although we've talked about a lot of tools. Really, what we think defines, or what I think defines action research is that it's action to solve a problem. And using this data, supporting citizens to gather data, analyze data, and to take action there's a lot of complexity in there, but it's very possible, and there's a lot of long-term work that's gone on in all three of these countries to advance that. So if presenters have any questions for each other, if anybody else has any questions, please just let us know. I'm looking at the discussion box. I don't see anything. And anybody can also just feel free to unmute yourself and share your video if you want, if you have any questions for any of the presenters. Neeta, do you want to maybe pull up the presentation again? The last slide from our side has the information about all of you and the organizations, in case anybody wants more information. I would say, as Accountability Research Center, we have interacted with a lot of different, sorry. We've interacted with a lot of different really interesting organizations supporting citizen research, citizen-led research. And Neeta, was there a slide at the very end that had the information, the website for ANANDI and CEGSS? I'm not sure. Yeah, that would be a great one to show as we're wrapping up. Okay, cool. Thanks, Neeta. Yes. Walter or Vincent or Neeta, any final questions or comments for each other, or?
Yeah, maybe what I would say, Angela, is that the level of engagement keeps changing depending with the level with which you are engaging, or the community advocates are engaging, and the level of support keeps changing depending on what level they are engaging at. Walter made in his presentation talked about some of the ways that the volunteers were reaching out at the national level. But I would love to hear more about how this happens, because in our case, the level of support kept changing, and the level of evidence that comes through and the expectations of it keep changing as you go higher. And this was something that we realized with the advocacy campaign. For instance, when you look at the decision makers at district level, when they received specific information about health workers in their specific facilities, health worker Vincent Mujune attended for only 2 days in 14 days, was so empowering for the decision maker to go and actually take a process of verification, and if they found something, then they would end up making an action quicker than it would if it was just a basic government system for monitoring services. Usually what happens is they will come up with an analysis and tell you a very hypothetical story about the problem, but the decision maker can't put their decision on a name, and that makes it difficult for them to act. So that was an experience at district level, and yet it changes so much when you go to the national level, because the mandates are different, and the requirements for evidence also become different. Thank you.
Yes, if I can give some an answer to recent questions. What is very important in work with citizen researchers is to reflect, to contemplate about sort of tactics and strategy we're going to use. For instance, one example of how we reach the national level is that for a while, community there had been collecting complaints of patients that needed to refer to a hospital, but not refer. They receive legal charges demanded by the driver of the ambulance, and this report to provincial authorities, and they always say, no, that's not possible. We cannot do that. I mean, that's totally illegal. People charging for that. No, that's not possible. We do not believe that is occurring. So we continue reporting, defenders continue reporting, and nothing was done. So once we have a database of over 100 complaints, the strategy for is to translate the database to journalists, investigative journalists, they could actually go and there's a serious problem of
Uh-oh, I'm not sure. Maybe Walter's having some connectivity issues. I think he cut off. I think the line that he was walking was discussing the importance of having information that speaks to action. Okay, how can we use the data developed, collected by citizens to actually engage the right officials? Okay, I think Walter's back. Are you there, Walter?
Yeah, sorry.
Okay, good.
I didn't the story that I lost connection, but just to summarize, is that the central level pays attention to the community defendant because they are bringing unique evidence that they do not collect. And secondly, that evidence can be verified. And so, and because of the training that they have received, they make sure that the evidence can be verified independently. And also they use different sector or branches of government to support this engagement with national level. For instance, the story that I was saying, it was using journalists so they could publish what's going on in a national newspaper. Some other times they have used the ombudsman to be an observing and intermediary with national level authorities. And some other time parliamentarians that are interested on public funding for health. So the national level interaction has occurred because, as I'm saying, of different strategies they have been pursued, and also using the information that they have collected and ensuring that it is a good quality information, but all is a verifiable information. I'll stop there.
Thanks, Walter. I think that's something that's come out from all the presentations, that citizens are uniquely positioned to gather information, data that the state doesn't have access to. They can shed a very unique perspective on the problem from the perspective of the citizen, which oftentimes that is vital for decision makers who want to make change, who want to do something positive. So I think that's a really interesting common theme across, as well as the importance of organizing across communities. How do you prepare communities to engage and also support them if there is backlash, if there is retaliation from the state, and working across different levels, whether it's the subnational level or connecting to national offices like the Ombudsman or the Inspectorate General of Government, or as in India, just really rooting the work of citizens and community monitoring and community action in the rights of the host of the country. So there's a distinct right to participate in Guatemala, and in other countries it may be the same, it may not be the same. So how do you leverage the legal environment to support the engagement of citizens with the state? So we only have about 5 minutes left. I know that HSR is going to have a short announcement at the end. I don't see, I'm just going to check the discussion one more time. I don't see any more questions, but I really strongly encourage you. It's been a huge honor for me to work with Walter and Neeta, and also Sejal, her colleague there, in Anandi and Vincent to pull together this presentation, this session. We really thank all of you for your participation, and please follow any of these organizations on their website or on social media, or feel free to reach out and email any of us directly if you have questions, or if you want to share more tools or more learning about what you have done. I think I will see if any of my co-hosts have any other things they wanted to say as a final thanks or parting words. Neeta, Walter, Vincent, anything final to add?
I just want to finalize inviting people to check our website. If they have any information more that they would like to know, they can always email us.
Absolutely.
Yes, and there are some videos on YouTube, and there is a Facebook page which is more active and vibrant, and we are a women's organization, so health and other rights of women are important area of our work. So do visit our website and do get in touch with us.
Yeah, I just wanted to say that Angela and I have worked on a working paper for the ACT Health, the Accountability Can Transform Health program project that we've been talking about and the experiences therefrom. I'm inviting you, there will be a link for this working paper on the ACT website. And so I'm inviting you to follow the processes, follow some of the writings that were written directly from the experiences that we had in Uganda. Thank you.
Yes, thank you for mentioning that, Vincent. So Vincent and I have a working paper that should be posted on the Accountability Research Center website very soon, going into a lot more detail about the people-centered advocacy work, processes, training, tools, and outcomes. And on the Accountability Research Center website, you could also find a few documents, a few working papers, or accountability notes on the work of CEGSS in Guatemala. That should also be available on the CEGSS website. And we haven't yet co-published anything with ANANDI, but I hope that that's coming in the future, Neeta and Sejal. We'll follow up on that after this. So this is just an announcement from the organizers of Health Systems Research 2020 about this project, which is ending January 31st. And HSR organizers are really requesting that you visit the website that's there on the screen and engage in this project. So thanks, everyone. I'm sorry if we missed any questions, but really appreciate your joining our session. Wish everybody a good day or a good evening, wherever you are.